Hello, everyone. Welcome to the Oncology Data Advisor Fellows Forum. Today, we have a very special edition where we are going to be talking about everything and anything lung cancer in honor of World Lung Cancer Day, which is celebrated on August 1st of every year. I'm joined today by Beth Sandy of the University of Pennsylvania and Dr. Morana Vojnic of Northwell System. Welcome to you both.
Thanks for having me.
Thank you.
Let's kick it off with you. Is there any specific topic that you were hoping to kind of really reinforce with our clinician audience here today?
Yeah, thanks. I am a nurse practitioner at the University of Pennsylvania. Like you said, I've had, over 20 years now in thoracic oncology. And I just think for me, the biggest part is continuing to make sure that we are doing molecular testing on our patients with non-small cell lung cancer, predominantly those patients with non-squamous or adenocarcinoma. I know we're going to talk a little bit about some of the updates in targeted therapies from ASCO in this past year, but you really can't use them unless you find them. And, we have been making better strides over the years. The data has shown that, about 66 to 70% of patients now that are eligible for biomarker testing are getting it done, but we're still probably missing about a third of those patients for whatever reason. Maybe there's not enough tissue and, time. There's so many barriers that we could talk probably for 20 minutes just about those barriers. But I think for me, the really important thing in non-small cell lung cancer for sure is to identifying these patients. Every single patient with a non-squamous non-small cell lung cancer should be getting that full next-gen sequencing biomarker testing. And even some of those patients with squamous, really. I don't know about you guys in your practices, but we certainly have those patients with squamous or mixed histologies that maybe have been minimal smokers over the years, or they're very young and you're questioning, their lung cancer diagnosis. These are the patients that I'm also in the squamous population going to be testing as well. And making sure we're doing that broad molecular test. This year, the NCCN has really strengthened their language around adding liquid biopsy to that tissue biopsy, saying that there really is sufficient evidence now across different clinical trials to support the use of both tissue and liquid biopsy up front to catch some that one or the other may be missing. So in my practice, we've certainly been doing that. And, I do think that we're catching more of these patients and then being able to give them their appropriate targeted therapies. I think there was also some updates in small cell lung cancer that Morana, you're going to talk about as well. But I think that's a place where we have not seen a lot of updates over the years. And now with immunotherapy and some, the bispecific now that's out, this is really exciting. So I'm going to hand it over and talk more about how we can treat these targets and small cell lung cancer once we figure that out.
Yeah, absolutely. And thank you so much for that very important introduction. Even in the course of my training, which has just recently concluded, we've seen a really broader uptake of comprehensive genomic testing. It goes by several names, but we kind of get the idea. We're looking for generally next generation sequencing of tumor tissues or blood, if possible. And what's been really encouraging is even on this very podcast, maybe about a year ago, we were talking about the need to advocate to make sure that these testing measures were guaranteed at the state level, maybe for agencies like Medicaid, for example. And I think I just recently read in JAMA up to 13 states have finally instituted that. And that list might be even larger since I read that dated issue. And it's very encouraging to see not only the NCCN taking a stronger stance, but also see that reflected at the legislative level in many jurisdictions. So kudos to everyone in the audience who continues to advocate for our patients. And hopefully we can kind of continue that momentum moving forward.
Longevity's done a lot of work around a group called the Cancer Precision Medicine Commons, and they've done a lot of grassroots patient advocacy, trying to get that legislation through to get this test covered. And you're right, it is at a statewide level. So it's getting better and better. But thank you for pointing that out.
And with that, also, it gets better in terms of, reimbursement for insurance companies for the patients. So they would not get that extra burden of getting a bill at the end of the day, which is also clearly important. But if you guys don't mind, just as you said, Beth, I think it's very important to emphasize that testing is not done just for the sake of testing. It's done because it does change your management at the end of the day, and it gives superior outcomes. And now we have several, so not only one, but several approvals for use in the clinic every day. We know that we've been using post-operatively, based on a DAURA trial, osimertinib, Tagrisso in EGFR mutant non-small cell lung cancer patients. But now, this year, we actually have also alectinib or Alcensa, which we used again in the post-operative setting for a similar stage of patients, so stage 1B and above, or greater than 4 centimeters. And it does confer superior outcomes to this patient, longer progression-free survival. So it's important to know all of these things in terms of upfront molecular testing, even for the early stage patients, which is not our usual practice, or has not been up until recently, if we're honest, because typically we would reserve that for our metastatic patients because we have several other targeted therapies. But now also in the early stage patients, just using these targeted therapies in the adjuvant setting has confirmed significant benefits. So I echo what Beth has said. Testing is extremely important, whichever modality to employ to get your results. So that's in terms of the targeted therapy. But I think, as you mentioned, we also had some exciting approval this year with small cell lung cancer, which we have not had an approval for quite some time, with tarlatamab, so bispecific BiTE for recurrent small cell lung cancer, which for now we had actually lurbinectedin alone in this setting that was recently conferred some benefit. And now we also have another drug, which is a bit probably more complicated to give because you have to be more monitored. But as long as you're in a big institution where you can have the inpatient component of it and monitoring as needed, it is definitely feasible. And again, conferred significant benefits for these patients, which had pretty limited treatment options up until recently, if we can say that. In addition to that, going back to the targeted therapies, I think there were quite some important few updates this year with ASCO, which we don't have approvals yet for that specific indication, but I think we are going to have it. I think you both agree we're going to have those, which is using Tagrisso also in the stage 3 setting, based on the LAURA trial. I think that's going to happen at some point, sooner or later. Because again, these targeted therapies and these patients with driver alterations with non-small cell lung cancer do definitely have benefit with targeted therapies over if you would have to use perhaps immunotherapy, which we typically avoid and not use in these patients. In addition to that, an important update from ASCO this year, and I think we had discussed it before as well, was the Adriatic trial. The use of, again, durvalumab in the chemo-RT setting for the small cell lung cancer patients, which, again, is not approved yet. We're hoping it will be in the near future. But again, an important update for the small cell lung cancer sphere, even in the limited stage setting where we have not had an approval quite even longer than the extensive stage small cell lung cancer. So these are kind of the things that happened probably over the course of a year. There were several others that have changed the landscape for these patients and are further going to change the landscape for these patients. And I think all the new opportunities are very exciting.
Absolutely, Dr. Vojnic, and thank you for that update. I really want to focus on one important real-world application of the data you just mentioned, and that relates to the recent approval of tarlatamab in small cell lung cancer, right? So, like you said, a lot of folks have access to larger centers. There's easy ways to be hospitalized for those first doses, make sure you're monitoring for things like CRS, et cetera. But I think what would be most exciting is for us to see maybe something like the first dose getting monitored and then later doses being able to give in infusion centers. This would really democratize access to this critically important drug. As you correctly said, we haven't had an approval here in quite some time. And my hope is we can see this very similar to what had happened in some of the lymphomas, for instance, with the BiTEs, where they're able to kind of change that monitoring to the outpatient setting. So time will tell if we're able to translate that to the community at large.
Yes, fully agree with you. It is exciting to have the approval. It's a bit more cumbersome to give it, clearly, compared to some other drugs that we do give. But as you mentioned, in the liquid oncology world or the malignant hematology world, there is some experience of translating this from the inpatient to the outpatient setting. So hopefully this will also be able to get wide network approvals or access to patients who are not perhaps so close to large centers, which could probably provide this treatment.
Yeah, without a doubt. All right, shifting gears here, I want to talk about all lung cancers on World Lung Cancer Day, and that includes the rarer subtypes like mesothelioma. Mesothelioma has actually undergone a pretty impressive amount of data in the past year or so. We heard a lot of chatter related to the Mars-2 trial. We've discussed this on this podcast a few months ago, and that's related to maybe the decreasing role in surgery, even in the earlier stage disease setting. But what I wanted to focus on was late-breaking abstract 8002, known as Beat Meso, or known by its cooperative group name as ETOP 1318. And basically what was happening in this late-breaking abstract is the investigators really wanted to investigate the role of combined PD-L1 and VEGF inhibition in conjunction with chemotherapy for all subtypes of mesothelioma. This is important, of course, because we know, especially in the sarcomatoid subtypes, dual PD-1 CTLA-4 inhibition with nivo/ipi has resulted in improved outcomes. And we know that the addition of pemetrexed to platinum has represented kind of a traditional standard of care, but the role of VEGF is kind of evolving. There was actually a wonderful education session from the ASCO session this year, and what's unknown is how that is added with PD-L1 blockade in this setting. So what the folks in this trial did was recruited 400 patients of all subtypes of mesothelioma, as I said, and they were randomized 1-to-1 to receive atezo, bev, and chemotherapy versus bev and chemotherapy alone. And we're talking about traditional endpoints here, primary being OS, secondary being things like PFS, duration of response, et cetera. Now, this is a late-breaking abstract only, so we only have access to the abstract and the slides that were presented, but let me try to distill it. Using the pre-specified cut endpoints for things like PFS and OS, the authors didn't see an overall improvement in a lot of the endpoints for any of the subtypes that were investigated. However, what was very interesting was that when atezo and bev were added to chemotherapy in the non-epithelioid cases, there was superiority, and I'll use that very vague word purposely, versus the epithelioid cases. This really kind of called my interest because, again, we're learning so much more about these sarcomatoid and biphasic disease settings where even though there's maybe a colder microenvironment, we're able to kind of unleash some responses when we add novel therapies. So I kind of left this abstract thinking, wow, I wonder if this will kind of take off, and I can't really wait to see the data. I don't know if either of you had a chance to hear this presentation or if you had any thoughts on it as well.
Yeah, I got a chance to review it and hear it, and I agree with you. I think it's pretty fantastic, especially in this area also where we have not had much happen in the last few years. I am looking forward to the subsequent approval studies, large-scale access to patients for these kind of treatments, but it's definitely very, very encouraging for the future for these patients as well, because though much less frequent than non-small cell, we still see it quite a lot. Yeah.
Absolutely. Yeah, I think any news is good news in a disease like mesothelioma, where outcomes are traditionally poorer compared to other lung cancer types. But we are seeing kind of a worldwide embracing of research in the area. So hopefully time will tell and yield some more treatment advances for sure. All right. Did either of you have any closing comments to finalize our World Lung Cancer Day podcast?
I'll just say that I think there's a lot of hope in the pipeline for both lung cancer and mesothelioma. There's so many clinical trials that we're participating in right now, and just looking at combining target therapies with other modalities. So I just think there's a lot of hope out there, and stay tuned. There's a lot going on in lung cancer.
I agree with Beth, and I think education, patient education, provider education is key, and provided access, wide access to anybody to certain treatments, novel that are becoming available is also extremely important. So just keep on going, keep education, keep reviewing, keep talking to each other.
That's a perfect segue as we kind of end this podcast today, remembering that Lung Cancer Awareness Month is just a mere 3 months away, the month of November. So we have to make sure we continue educating fellow healthcare professionals, our patients, patient advocates, everyone else in the community who helps with the care of patients with lung cancer. Thank you both today. That concludes our podcast. Nice seeing you.
Thank you. Bye.